Hi, my name is Julie Kamisha, and I'm presenting my case study on herpes zoster. The case involves a 56-year-old male patient who was diagnosed with herpes zoster at a local walk-in clinic. He was given gabapentin 300 milligrams 3 times a day. He presents to you today seeking a second opinion. Richard is a 56-year-old white male who presented to the office complaining of painful blisters along the right side of his trunk that first appeared as small red raised bumps 3 days ago. His pain is a 7 out of 10 in severity, and he states that the blisters have started to break open. He describes the pain as searing and that a watery fluid leaks from the blisters. 2 days prior to developing the rash, he also reported a subjective fever. He didn't actually take his temperature, but he felt warm, and a feeling of general malaise. He remembers feeling some itching and tingling along the right side of his back and side before the rash developed. Richard went to a walk-in clinic in his town when the rash developed on that first day. He was diagnosed with herpes zoster and was prescribed gabapentin 300 milligrams 3 times a day. He's been taking the gabapentin for the past 2 days, but he has experienced no relief from his symptoms, and he's still noticing new vesicle formation. He's wondering if there's anything else that he can take to help with the pain and shorten the duration of his symptoms. For Richard's past medical history, he has hypertension and depression, for which he takes lisinopril and escitalopram. He had knee surgery at the age of 52, and it is notable that he did have chickenpox as a child. His father passed away from a stroke at age 81. His mother is still alive and lives at an assisted living facility and suffers from dementia. He has no known allergies to any medications. Richard got a divorce in 2019 from his wife of 26 years. He now lives alone in a condo, and he has 2 sons that come to visit him a couple times a year. He has 3 to 4 drinks per week, and he golfs with his coworkers on the weekends, and he feels like this is fulfilling for his social life. He does little to no exercise other than walking during golf, and he's currently a non-smoker and never has smoked in the past. For the physical exam findings, I found Richard to be in no acute distress, but he did appear to be in moderate discomfort sitting in the exam chair. He was alert and oriented times 4. He was afebrile at this time. I have included an image of Richard's rash along the right side of his trunk. You can see the vesicle formation as well as how the rash follows along in a dermatomal pattern. The diagnosis of herpes zoster is typically made based off of characteristic clinical findings alone, as the virus is difficult to recover from swab samples of the lesions. For this reason, no lab or other diagnostic imaging results are presented. Richard did report that the rash was painful to my touch. It is also important to note that the rash did not cross the midline of his back. This is characteristic of herpes zoster infections as they follow along a specific dermatome. In terms of any differential diagnoses, other conditions that could have been considered would include contact dermatitis, which is something that you can usually parse out in a thorough history taking, such as asking if he had started using a new detergent or come into contact with any new plants in the environment. Even less likely, herpes simplex virus could be considered. However, Richard's presentation of the characteristic prodrome symptoms and the distribution of his rash can be diagnostic of herpes zoster infection. Herpes zoster, which is more commonly known as shingles, is caused by the varicella zoster virus. This virus operates in 2 phases. The primary infection, which is chickenpox, commonly occurs in children, and the secondary infection, which is herpes zoster or shingles. Following the primary infection, the virus lives in the dorsal root ganglia as a latent virus. Herpes zoster later develops when that latent virus becomes reactivated. This can be random or due to stress, surgery, disease, or in immunocompromised individuals. The reactivated virus then travels through the dorsal root ganglia and eventually reaches the epidermis or the outer layer of the skin. This is why herpes zoster rashes follow specific dermatomes of the body. The stress from Richard's recent divorce is the likely trigger for this outbreak, which would be something that you can find in his past medical history. The varicella zoster virus and herpes zoster will follow 3 stages of infection. First is the prodrome. Prodromal symptoms of herpes zoster include fever, malaise, headache, and photophobia, as well as itching, burning, or tingling at the site of the future rash. This only lasts for a couple of days before then moving on to the acute eruptive phase. Within a few days of these initial symptoms, somewhere between 2 to 5 days, the characteristic erythematous maculopapular rash erupts along a dermatome. The rash progresses to form vesicles that eventually erupt and scab over. The initial rash to scab formation process typically takes about 10 days. However, full healing of the lesions can take up to a month. The dermatomes most commonly affected are of the face or torso. Herpes zoster of the face is significantly more dangerous and can cause long-term damage to your eyes, causing vision problems, your ears, or to the facial muscles. Finally, post-herpetic neuralgia is the 3rd stage. Not everyone will develop PHN, as it's called. This is a chronic complication of herpes zoster, and it is defined as pain that persists for longer than 1 to 3 months after the resolution of the rash. Older patients are more at risk of developing PHN. Those with PHN complain of chronic pain to the previously affected area, mostly described as a burning sensation rather than that acute pain from the 2nd stage. Even the slightest pressure from clothing, bed sheets, or the breeze going by can elicit this pain. My treatment plan for Richard includes antiviral therapy in the form of Valacyclovir, 1 gram by mouth, 3 times a day for 7 days. Valacyclovir is a prodrug form of acyclovir, meaning after intestinal absorption, it is converted to acyclovir via hepatic metabolism. This antiviral medication is a nucleoside analog, and it slows the growth of the virus by inhibiting DNA synthesis. It is important to note that antiviral therapies do not cure herpes zoster. It can only shorten the duration and reduce the severity of symptoms. UpToDate also indicates that antiviral treatment may also reduce the incidence or severity of post-herpetic neuralgia. Valacyclovir is excreted by the kidneys in the urine. Antiviral therapies for herpes zoster are recommended for patients who present within 72 hours of rash formation. They may also show benefits for patients presenting after 72 hours who are still developing new vesicles. Richard is a candidate for antiviral therapy as he presents on day 3 of the rash and due to his older age. The benefits of antiviral therapy are greatest in those over 50 years of age due to their greater risk of developing chronic pain following this active infection. The ultimate goals of treatment will be to treat the acute viral infection, treat pain, and prevent post-herpetic neuralgia. Valacyclovir has very few adverse drug reactions. It's a generally safe medication. Some reactions that can occur are headache, nausea, vomiting, diarrhea, and renal dysfunction with very high doses. It's important to note that renal dysfunction typically only happens with IV administration of Valacyclovir. Valacyclovir also has very few drug interactions. It's, again, a pretty safe medication. Richard should avoid concurrent use with probenecid and cimetidine, and there is that risk for renal toxicity when combined with other nephrotoxic medications such as NSAIDs. Seeing as there is no real cure for herpes zoster, there are many other options that could be considered to treat Richard. Acyclovir is generally thought to be the gold standard for treating herpes zoster. However, it does have some limitations. It is slightly less expensive, but Valacyclovir is not an expensive drug to begin with. I looked up Shaw's, which is a local grocery store. 30-day supply from their pharmacy of Valacyclovir is only $16.26. I believe acyclovir is only marginally cheaper than that. Acyclovir also requires more frequent dosing, and it's very much less bioavailable in the body. Valacyclovir yields peak plasma concentrations that are 3 to 5 times higher than that of acyclovir. Valacyclovir also tends to be a better choice for these reasons, and it has been shown to be more effective at preventing PHN in older patients than does acyclovir. Richard rated his pain a 7 out of 10 in severity, which indicates that he will need some form of medication for pain relief. For more mild cases, Tylenol can be used to alleviate the pain, but in Richard's case, he will likely need an opioid analgesic such as oxycodone. This would be prescribed on a regular dosing schedule rather than an as-needed basis, as this better controls pain and reduces anxiety surrounding the pain. Tramadol has also been shown to be particularly effective against the pain caused by postherpetic neuralgia. For patients with uncomplicated zoster, there's typically no role for adjuvant therapies such as steroids, anticonvulsants, or tricyclic antidepressants. These therapies often come riddled with side effects of their own and may potentiate other serious reactions. For example, corticosteroids increase the risk of secondary bacterial skin infections in those with herpes zoster. As for the gabapentin that Richard was prescribed by the clinic, the research is thus far inconclusive as to whether or not gabapentin reduces the risk of developing PHN. There is recent research that indicates that gabapentin may even be a harmful addition to the treatment regimen. A study published in PLOS One in 2019 looked at patients older than 50 with herpes zoster who were either given a placebo or gabapentin in addition to valacyclovir. Their research found that the addition of gabapentin provided no significant pain relief, and those taking gabapentin reported worse quality of life and poorer sleep quality. In addition, 3 patients discontinued the use of the gabapentin due to adverse effects. I would recommend Richard discontinue the use of the gabapentin he was prescribed, especially if he were given opioid analgesics due to the increased risk for respiratory compromise with both of these medications. Gabapentin also poses a higher risk of certain adverse drug reactions, such as dizziness or drowsiness in older populations. Another adjuvant therapy that is sometimes used is capsaicin topical cream. The brand name is Zostrix, which is pictured here. This ointment works by releasing substance P from nerve fibers, causing a burning sensation, which is pretty mild, and then this elicits pain relief after the substance P is depleted from the nerve fibers. The goal of antiviral therapy is to reduce the severity and duration of Richard's symptoms, as well as reducing the risk of him developing postherpetic neuralgia. Valacyclovir does not need to be taken with meals, but it should be taken with a full glass of water. Richard should also remain hydrated during therapy to prevent renal complications. Again, renal dysfunction is very rare and is only usually seen in high IV doses, but signs he should report to the provider include decreased urine output, fluid retention, or any cognitive changes. Richard should also keep the lesions clean and dry, and he should be educated that he can only spread the virus during the blister phase of the rash. He is no longer infectious once the rash crusts over. Richard lives alone, but he should avoid spending time with his friends or having family members over to visit until the blisters have crusted over. It is especially important to avoid interacting with any immunocompromised individuals during this phase. Richard should also avoid drinking alcohol while he is taking the valacyclovir. There are currently 2 vaccines available to prevent herpes zoster. The preferred vaccine is Shingles, which is a recombinant vaccine and has been in use since 2016. The CDC currently recommends that healthy adults over the age of 50 get 2 doses of the vaccine, separated by 2 to 6 months. These 2 doses are more than 90% effective at preventing herpes zoster. You can get Shingles even if you have had shingles in the past, as this prevents future occurrences of the infection. Richard should wait until his rash has gone away before getting vaccinated. Patients can also get Shingrix even if they are unsure about having chickenpox in the past. Zostavax is the other vaccine available, and this is a live vaccine that has been around since 2006. Those over 60 can get Zostavax if they are allergic to Shingrix.